let's just see, 10 mils might be enough. Okay, it's working. Take the air out again. Load the introducer. Probably not absolutely essential to have the introducer, but there we go. Then we get our scalpel.
We don't have.
Yeah, clean, be sterile. Yeah, look what we've got here. And I've got something else that I can show you. It's going to be a nice CVP type needle. Alright, so we've got our little scalpel. We've found our landmark, made an incision. I'm not going to cut it again, it is actually already cut. Alright, then we turn the blade around. This is actually a silly blade, can you see, because it's a bit flat. So then you put it into that incision, alright, the back of the blade, and turn it to right angles. Okay, that's what that maneuver meant. Take the tracheostomy tube and advance it in. I think this might be a jet insufflation model. Okay, advance it all the way down. This just removes by twisting and ventilate. Okay? Easy as that. It's actually not a difficult thing to do. The difficult thing is finding the landmark, but you're going to remember, examine every patient's cricothyroid membrane from now on. Then, oh, sorry, forgot to inflate the cuff. Okay, so then you'll be able to find it. Okay, so I'm not that sure why it's got ventilation ports on the side. I think this is actually a tracheostomy, and it might be that it's quite low down near the bronchuses. Maybe introduce that. There we go. Okay. Alright, so just jet insufflation when you don't have a fancy coniotomy set. You're going to use your large, I can't use a orange gel because you know they've got safety needles. Once the needle's out, you can't put it back in again. But essentially the same thing, my Gelco is going in with my syringe attached. Oh, this is what I was going to say. Put a little saline in it and just squirt it through so that the tube's got full of saline. Then otherwise you can sometimes get a little skin plug there. And make a little incision, even if you just use the edge of the needle. Alright, just incise the skin. Especially when you're putting fat cannula into skin. And you can sometimes, some people's skin are very tough. You get a little fat globule or something in there. So if you just put a little bit of saline in there, and then advance it in 45 degrees quarterly. Basically, if you don't feel resistance, you're in. And now you must attach it. Can you see what the problem is here? That's to there. Alright, so you need a three-way tap. And if you don't have a three-way tap, you want to say a 5-ml syringe. One of these that come with the end of a, is there a 5-ml syringe there? Okay. 10 ml. Anyway, what you will find is that, did you see where I pulled this off? The back of any ET tube. Alright, this will fit into the back of a 5 ml or 2 ml syringe. You can use this as well. Alright, so you've got your little 5 ml or your little 2 ml syringe. Sometimes you need to be a bit of MacGyver, okay? You need to actually take a bit of oxygen tubing, try and get it to fit over that, try and get this to attach to it. You can attach your bag. Just remember, somewhere you need to make a little hole to allow ventilation. Right. And another little tip for intubating. I'll take this one off. These things fly off like nobody's business. These little things that are on the end of the ET tube. They don't have a name, so generally we ask for that little thingy. Okay, and I would say at least out of every second intubation, this one disappears. Okay, and then suddenly you're so happy you got the tube in, but now that's gone, and now this, you can't connect those two. Okay, and when I was at my very first recess that I was called to the ward, this is what happened, and I thought, oh, something's missing from here. I thought this was the problem. I thought they'd given me a bag that was faulty, and I didn't know what to do. So I just pulled the tube out again and then just bagged the patient. Because I actually didn't realize that this comes off and it can disappear, etc., etc. But it does happen, and it happens quite often. And if it does disappear, then you just open another ET tube, and you take the little thing out of the ET tube. Whatever you do, don't pull the ET tube out. Okay, just open a new packet and get a new little thingy. Okay, that happens, and that taught me out. So it might happen to you as well. Okay, then so we've said pass the tube. The fifth P was position. We did that. That was actually checking the position of the tube, and post-intubation we can also always ask. And the last P is post-resuscitation care. So that's not what the point of today's discussion. Post-resuscitation care is putting a patient onto a ventilator, tying in the tube, getting an X-ray to check for the position of the tube, getting your capnography going, doing a 12-lead ECG, doing a blood gas, contacting ENT or whatever to come and see your patient. So the last P is post-intubation care. And if you want to get 100% for a simulated intubation scenario, if you say all the 6 Ps, you will always pass, because if you didn't intubate the patient and you prepared properly, you'd have your adjuncts available and you'd pass, because that's the point. If you're prepared, you can always get away with an adjunct. Okay, so what do you guys want to do? You want to practice all of these skills?